Good afternoon. This is Tom McCarthy from McCarthy & Cox, and welcome. We're excited to have you today. And the next in our longstanding series of webinars, this is a webinar that will tackle the issues around Medicare that I know a lot of you have. It's called Medicare 101. We want to encourage you through the course of this webinar. If you have questions that pop up in your mind, there should be a chat button on your screen where you can submit a question. They'll come to me, and at the end of our presentation, we will take on as many of the questions as we can. And I know Medicare for most people is very confusing. Today, our speaker, our presenter is a gal named Kerry Quick. We've had the privilege of working with Kerry for the past several years. We don't do Medicare insurance or Medicare supplements in our office. We rely on Kerry and her team at Seniority Benefit Group to help guide you through this maze of all the different options that are available to you and to find a solution that's cost effective and really fits what you're trying to do. And we get nothing but rave reviews, Kerry. We feel very blessed to have you as part of our extension of our team, and we're glad to have you. Before we let Kerry start, I just want to tee up an idea, just so you know. Next month in August, on Wednesday, August 18th, we have a very special presentation called Empower, Elevate, and Achieve, a financial guidebook for women. So all the gals that are here watching today, or if you have a gal who's important in your life, this is a workshop they're not going to want to miss. Unfortunately, the great majority of women at some point in their life through death or divorce end up on their own. Many times they're not quite ready for that to happen. So we would encourage you to get involved with your finances, and both husband and wives be involved, be knowledgeable, and we're here to help you do that. So today, without further ado, I'm going to let Kerry take over. I'll be back at the end. Meanwhile, I'll be in the background taking your questions and summarizing them for Kerry when we come to that point. So Kerry, welcome. We're very pleased to have you, and I know you've got a lot of information, so I need to let you take over. So thank you very much.
Thank you, Tom. Thank you so much for having me. And just for everybody in attendance, I've had internet issues in my home for the last 17 months. So if my audio gets wonky, if someone would please point it out to Tom in chat, that would be helpful. I can move to a different location in my home so that it's not breaking up. So with that, once again, thank you, Tom. I have enjoyed so much working with the advisors at McCarthy & Cox. We work with a lot of financial advisors throughout Central Ohio because sharp financial advisors know that they don't typically want to touch Medicare with a 10-foot pole, and we're happy to take that on. I always start these sessions by explaining to people how we got into this mess, and I say that with affection because we truly love what we do. For many, many years, my company, under a different name, managed group health plans for employers, smaller employers. And what started happening was we started getting more and more calls from people within those groups asking for Medicare guidance. So initially, when we got into it, it was just in an effort to help. It wasn't long after we did that we saw two things. One, it's very difficult to navigate if you don't know what you don't know. And two, we started to see pretty significant financial implications where we realized even if someone chose to work beyond 65, more often than not, it made better sense for them to move away from the employer plan into their own coverage because it was more cost effective. That has become far more pronounced in the last 10 years. So long story short, we huddled one day in our conference room and decided to focus more closely in this area, which was a brilliant decision in hindsight, because when the Affordable Care Act was passed, many of those small groups that we represented went away. So today, we're very proud to share that we're really the only company in Central Ohio who does what we do, in that we are 100% focused in Medicare. We don't do anything else. We don't sell life insurance Monday through Wednesday and then Medicare for the rest of the week. We're independent. We work with all of the major insurance companies that maybe some of you are hearing from, depending on where you are in your eligibility. We're not married to any of them. Our role is truly to educate and facilitate coverage options, or educate about them, I should say. So with that, I'll get into the presentation. This is strictly educational, so I won't be permitted to get into any plan specifics or even share the names of the companies that we work with, but you can just kind of piece it all together. If anyone has questions that they're not comfortable, I should say, asking through the presentation or at the end, please don't hesitate to contact me after the fact. So let's get started. I've already given you some history about who Seniority Benefit Group is. We are local. We think there's still a lot to be said for local presence. I'm sure everybody on this call appreciates that because of the local presence in Marysville with McCarthy and Cox. As I already mentioned, we are 100% Medicare focused and independent. That's important. It's important that when people come into Medicare, they get introduced to the entire playing field, not just one piece of the pie. So today we're going to talk about basics, what to expect when you turn 65, the basics of Medicare, what your options for coverage are, enrollment dates. Of course, everyone wants to know how much everything is going to cost. And then at the end, we'll talk about how we work with our clients. It is not at all uncommon for people to come into our office with reams of paper that they've received. Typically at about 64 and a half, that's when the marketing begins. And I'm careful to point out right out of the gate that between the marketing materials, the advertising that you hear on television, and then of course, all of the commentary from your friends and family, it gets really overwhelming. Our role is to try to simplify all of that. I'm also careful to point out that while we still live in a free country and can buy whatever we want, not everything is going to work. So typically if someone brings a pile of paper like that into the office, we're able to whittle it down to a fraction because not everything is applicable to them. We are not fee-based. We do not charge fees. Frankly, the only way we are compensated is if we in fact file an application for coverage. So we tell people, you know, you certainly can do this on your own. You can go direct to the insurance company. It's not going to cost you any differently than if you work with us. What you do get with us is the ongoing advocacy. So you know about changes coming up in the health insurance market and those kinds of things. Medicare has been around for decades. It truly hasn't changed a whole lot since 1965. It's been improved and tweaked along the way, but the basic footprint of Medicare remains the same. The biggest misconception is that Medicare is mandatory. It is not. It simply becomes an insurance option at 65. Whether or not you go there depends on your circumstances. You are not penalized if you don't apply for Medicare. The only time penalties come into focus is when you cannot show that you've had ongoing coverage. People defer Medicare every day. Perhaps not as often as they did, because as I mentioned, moving into Medicare tends to be more cost effective today, even if someone continues to work. The message we push out more than ever is don't assume if you have access to an employer plan or a retirement plan, it's your best bet. It may or may not be. The beauty of moving into Medicare for many people is that while they may have co-pays, they're not facing high deductibles, which are so common with employer plans today. I'm sure everybody in the audience has heard about the different parts of Medicare, the alphabet soup, as I call it. Part A is hospitalization. This is what you become eligible for when you turn 65. There is no premium associated with Part A, assuming you have 40 quarters of coverage or 10 years of work history. If someone does not have 10 years of work history, in some cases, they will draw on their spouse's number. If that's not possible, they would be facing a premium for Part A. Part B is strictly outpatient. That's your doctor visits, lab, anything outpatient typically falls under Part B. Part C is actually a technical term, or the technical term for a coverage option, that coverage option being Medicare Advantage. And then we have the newest part of Medicare, Part D, which came into existence in 2006 via the Bush administration. As I mentioned, when you turn 65, you may have access to an employer plan. You may have access to a retiree plan. We certainly encourage anyone eligible for VA benefits to pursue that, even if it's just the prescription coverage, because it can be very, very helpful if someone is taking expensive brand name prescriptions. Most people, however, when turning 65, will fall into one of the two categories on the right. I always tell people, while it appears as though through all of that marketing and advertising that you have hundreds of options when you move into Medicare, in reality, you have two. It's either a Medicare supplement with a separate prescription plan, or a Medicare Advantage plan where drug coverage is built in. Keep in mind, the word supplement, supplemental, tends to be used as a catch-all for everything, but it in fact is a very specific product, which we'll talk about. Generally speaking, when we talk about original Medicare, that being parts A and B, we're talking about an 80% plan with no prescription coverage. So ultimately, what we do as a company is explain to people in what we hope is plain English what their options are, how they work, how they differ. What their options are to address that 20% that's not covered, as well as any prescription needs. As I already mentioned, there's typically no premium associated with Part A, but you've paid for it all along, as through payroll taxation, as in the years that you work. We're careful to point out that while Medicare is not mandatory, as many people believe, it is an insurance option, and just like an insurance company, there is a premium attached. The standard Part B premium currently in 2021 is $148.50 per month per person, unless you fall into a higher income bracket. When you apply for Medicare, there's a 2-year look back. So today, if someone is applying for Medicare, the government is going to use their 2019 tax return to determine the Part B premium. For a married couple filing jointly, if their modified adjusted gross income was greater than $176,000, they will pay more for Part B. How much more depends on reported income. And it's not about who made what, it's about the reported income. For someone who files as a single individual, the threshold is $88,000. If someone falls into a higher Part B premium, they also pay a surcharge for Part D as in David prescription. That came about via the Affordable Care Act. There was language in the Affordable Care Act that spoke to the eventual shrinkage of the donut hole that we have with Medicare drug, which we'll talk about also. The way that that effort was funded to shrink that donut hole, big pharmacies stepped up, and now we have discounts that we didn't have, and higher income individuals pay assessments to fund that effort. As I mentioned, generally speaking, parts A and B cover 80% of your health care. Medicare supplements, also known as Medigap policies, very specific product. Medicare supplements were the only option available to Medicare eligible folks for decades, from 1966 until the late 90s, early 2000s. This was the only game in town. Medicare supplements are private policies that you purchase from an insurance company that wrap around Medicare A and B and ultimately pay the 20% that's not covered. They are the more expensive way to go, not because they're superior products necessarily, but because you're paying ahead of time. You're paying more in premium each month so as not to come out of pocket after the fact in the form of copays. and deductibles. They are federally standardized, so a Plan G that we recommend today works absolutely the same way from company to company, but what can vary wildly are the premiums that insurance companies charge for the exact same coverage. So for the consumer, it should be a matter of understanding you don't get better coverage by spending more money, you're just spending more money. So you want to get in as low as possible with a reputable company. There are probably upwards of 40 companies in the state of Ohio who can offer Medicare supplements because they can. It doesn't mean that they're cost effective or competitive. As long as an insurance company has a charter to write business in a given state, they can write whatever they want. Several years ago, I had clients who came to me who at the time had their Medicare supplements with a car insurance company and were paying far more premium than they should have been. So case in point, it wouldn't occur to me, having been in the industry for a long time, to purchase a health-related. So that's an important thing to know. You want to get in as low as possible with a reputable company. Probably the number one reason that someone will go with a supplement today, well, a couple of reasons. One, they don't want to deal with any networks. With a Medicare supplement, you can go to any Medicare provider you choose. There are no networks. 10 years ago, that was a bigger deal than it is today because the networks on the Advantage side have gotten much broader. However, if someone tells me that they want to move about the cabin as they see fit and never have any restrictions, my answer back is that you're best served going with a supplement, and you will pay for it because not only are they the more expensive way going in, your premiums do increase each year. Over the last 10 years, I can tell you that a reasonable expectation for premium increases has hovered at about 5%. It could be a little less, it could be a little more. The older you are going into a supplement, the more expensive the premium. They are age-based. This is the only product in Medicare that is more expensive based on age. Medicare supplements are still considered to be private. They can be applied for and or canceled any time of the year. Open enrollment in the fall only applies to Medicare Part D prescription plans and Medicare Advantage plans. Medicare Advantage plans came about essentially when the government opted to outsource Medicare to the private sector, which gave rise to Medicare Part C, more commonly known as Medicare Advantage. These plans are federally subsidized. Every time someone enrolls in one of them, the government pays the insurance company a stipend each month to manage the claims so they don't have to. Drug coverage is typically built into Medicare Advantage, so you're not paying a second premium for Part D. Keep in mind, you are not forced to take out drug coverage when you are first eligible, but if you don't and elect it later, you will be charged a late enrollment penalty. So oftentimes people who are not taking any medication will go in the direction of Advantage because the coverage is built in whether they need it or not for no extra premium. When you hear the advertising on television regarding dental and vision and all of those things, first of all, please know that it's wildly overstated. The suggestion that you get on the television is that there's a holy grail of plans out there where everything is free, and that's just not true. Yes, most Advantage plans have allowances for things like dental and vision and hearing, but there's a lot of difference between allowance and 100% coverage. Dental and vision are probably the two most overstated benefit types on the planet. They never have been and probably never will be very robust benefits. Medicare Advantage plans are network-based. They are typically PPOs and HMOs. With a PPO, a preferred provider organization, you have both in and out of network. You're best to stay in network in an effort to keep your costs down, but if you had to go out of network, you could. In an HMO, health maintenance organization, you're either in network or you're not. There is no out-of-network provision. As I mentioned, with all of the companies who offer Advantage plans, the networks have gotten very, very broad over the last 10 years. I can also tell you that when you've been in this business long enough, you come to know that all Medicare Advantage plans are regulated by the government the same way. The functionality is the same across the board, and that you're typically not paying very much, if any, premium each month, but you're paying as you go with co-pays. Where they differ is HMO versus PPO, and some companies have broader networks than others. But when people try to sit down and spreadsheet the various plans, thinking they're going to find big differences in co-pays, they get lost in the weeds in about 5 minutes. You don't see crazy, crazy differences. They're all very consistent. We have many, many hundreds of clients who are in Medicare Advantage plans where they're not paying any premium at all. Understand that when a company offers a zero premium plan, they're not suggesting it's free. The marketing is a little slippery, but what they're really saying is between the subsidy dollars that they're receiving and your cost sharing with co-pays, they are in a position to offer it to you at no additional cost, meaning on top of Part B. Everyone has to pay Part B regardless of the kind of coverage that they're in. So just to go back to supplements, with a supplement, you're paying more so as not to pay later, and arguably paying more so as to be able to go where you want. With an Advantage plan, you're paying little, if any, premium, but you're paying as you go with co-pays up to a limit. Every Advantage plan has a maximum out of pocket attached. This is not a deductible, as is often misunderstood. It's rather your worst case scenario. Every time you incur a copay, it gets applied to that maximum. Statistically, we know a small percentage of people max out. Nonetheless, if someone has a terrible year and they do max out, anything past that maximum is paid in full. So as we go through coverage options, we explain to people it's not so much about coverage as it is how you want to manage your out-of-pocket costs. And there's also a little bit of luck, because none of us knows what's around the corner. An example that I use that I think does a pretty good job of illustrating that it's not about coverage. I have a client who enrolled in a zero premium Advantage plan in 2016, not taking any medication, nothing going on medically. Fast forward 18 months, I got a frantic call from his wife telling me that he had just been admitted to Riverside here in Columbus and was being told that he likely needed open heart surgery out of nowhere. So of course they were wanting to know from me what they were facing cost-wise, and I reminded them that he would have a per day copay for the hospital stay. That's pretty standard in Advantage plans. A few months later, he shared with me that he was in the hospital 4 days, had the open heart surgery, incurred almost $450,000 in costs, which sadly is easy to do today. His out-of-pocket, however, for that hospital stay was $1,600, because in that plan, in that given year, he had a $400 a day copay for days 1 through 4. Had he been in 5 through 90, there wouldn't have been any copays. That $1,600 was then applied to his maximum out of pocket, which in that plan in that year was $6,700. Clearly, he wasn't going to even get close to his maximum, and he was aware that he hadn't been paying premium. Had he been in a Medicare supplement, he wouldn't have paid for that hospital stay, but he would have been paying significant premium for those 18 months. Having some issues here. Sorry about that. Okay.
Kerry, did we lose you?
Some plans will also have snowbird provisions, meaning if you're, do you have me now? Can you hear me now?
Yeah, you were cutting in and out there just a little bit. We lost you for about 10, 15 seconds.
Okay. The last thing I was talking about was the Medicare Advantage, the example about the hospital stay. Did you get that?
Yeah, all but at the very end when you were talking about his out of pocket was like $1,600.
Yes.
And then you kind of cut out right after that.
Okay, I'm going to move to a different area here. Yes, his Out of pocket was $1,600, which was then applied to his maximum, which in that given year was $6,700. So he clearly was not going to max out, and he was aware that he hadn't been paying premium. Had he been in a supplement, a Medicare supplement, he would not have paid for that hospital stay, but he would have been paying significant premium each month. So again, it's not so much about coverage as it is how you choose to manage your out-of-pocket costs. And then the snowbird provision, if people are out of state for a period of time, if they winter in Florida, for instance, many insurance companies will unlock the network in Florida or wherever they are so that their plan that's based here in Ohio works essentially the same way as it would here. And keep in mind, whether you have a supplement or an advantage plan, if you're traveling within the United States, you have 24/7 emergency coverage. And typically it is an emergency. Most people don't go on vacation with the idea that they're going to go to a doctor on purpose. Part D, prescription coverage is probably the part of Medicare that's still very confusing to people. Medicare drug coverage, whether it's a standalone plan working alongside of a supplement or where it's built into Medicare Advantage, it all works the same way. Medicare in and of itself does not offer coverage options. Everything is offered through private insurance companies. Medicare does regulate Part D plans. All companies who offer Part D prescription coverage are required to cover 2 drugs per therapeutic category. They don't have to cover everything. The adjustment that people face when they move into Medicare typically isn't finding a solution for doctor and hospital. That's easy enough. But prescription coverage can be a little more limiting with Medicare than what many people had experienced with employer coverage. So we encourage people to have conversations with their doctors to try to get as many of their prescriptions in generic form as possible. Every year, the government establishes an amount of money you're permitted to spend in drug coverage. This year, that amount is $4,130. Now, keep in mind that $4,130, and it changes each January a little bit. That $4,130 represents your copay, plus what the insurance company is kicking in to make up the difference. So in other words, when you fill a prescription, you're getting charged for the full cost of the drug, not just your copay. And this is what typically confuses people. So if you're taking a prescription that costs $100 and you go to CVS or wherever to fill it, your copay may be $10, but you're going to get charged for the full $100. If you exhaust that initial level of coverage, you now move in to what we affectionately refer to as the donut hole. The technical term is the coverage gap. This is good news, bad news. 10, 11 years ago, if you went into the donut hole with a $500 drug, you paid $500. Today, you'll pay about 25% of that. So the donut hole didn't close entirely, but it's a whole lot better than it was. Now, the bad news is that percentage, that 25% that you're going to pay is likely going to be more than what your copay was. Between that initial stage of $4,130 and what you come out of pocket in the donut hole, you can be out of pocket up to about $6,500. If you exhaust that, and very few people do, now insurance kicks back in and you're in the catastrophic stage. For some people, that's a silver lining because their costs plummet. However, they came out of pocket many thousands to get there. The point that we stress more than ever today, especially given the fact that Social Security is still in relative lockdown, start the process early. Your own personal open enrollment period begins 3 months before you turn 65, and that 3-month window is so important. That's the time when you need to start asking questions. If you plan on continuing to work, how does your work insurance measure up to Medicare? That's the time for due diligence to get your ducks in a row. I walk people through the Medicare application online, as a for instance. That's a 10-minute phone call versus hours at Social Security, which is not an option right now. Why they are reopening, I don't know. We've not heard any feedback on when they might reopen in full. I can also stress to you, and I'm up to my gills right now with a whole bunch of issues with people that unfortunately didn't get good guidance and are now scrambling to try to get their Medicare in place. While Social Security in one hand says your eligibility begins 3 months before the month of and 3 months afterwards, I'm here to tell you that when you try to get Medicare going in the 3-month window following your birthday, Social Security will arbitrarily bump out your Part B effective date, which can ultimately render you with no coverage. It gets really dicey. So ideally, if someone's going to move into Medicare, the time to do it is when they first turn 65 or many, many months afterwards. I always tell people, you know, even if I don't agree with something, as long as I can explain it, I'm okay. In this case, there is no explanation. They bump out dates because they can. If someone defers Medicare, the burden is now on them to show the government that they've had ongoing coverage. So you need to submit documents showing that you have had coverage. There are 2 documents: the request for employment information, where your employer goes on the record to say that you have been covered. And then the other is the actual Part B application, where you tell the government when you want Part B to begin. Part B can only begin on the 1st of any given month. Same thing with insurance options. It can only be the 1st. We can't make it the 15th or the 30th. So for those people, for instance, who need coverage by August 1st this year, I need to get them squared away by the end of July. We can supply you with that paperwork if need be. It just simply saves you a phone call to Social Security, because we will email it to you in a PDF file, whereas Social Security won't do that. They typically will send everything through the mail system. If you are coming up on eligibility, if you haven't already done so, you should set up an account at Social Security. Years ago, and I know the folks at McCarthy are familiar with this. Years ago, Social Security sent out a mass, communication encouraging everyone to establish online accounts, because they ultimately want to get away from sending out those paper statements each year. Now, in the midst of the online Medicare application, people are asked to enter their username and password that they created for their Social Security account. So if you haven't done that, that would be the first thing to do. As I mentioned, I walk people through the Medicare application every day because it's so much easier. And honestly, I started the practice because there are some questions on that application that people want to answer intuitively, only to then find that it wasn't the right answer. So we had to go back and correct everything. And I finally thought, well, this is silly. I'm just going to start walking people through it to save time. If someone is already drawing Social Security, they automatically receive a Medicare card. The reason being, this is dated logic given the new laws, but the reason why someone automatically gets a card is because the assumption is if you're drawing Social Security, you're probably not working and thus probably don't have insurance coverage. But in the absence of that, everyone has to physically apply for Medicare. It does not happen automatically. As I mentioned, everybody has to pay Part B premium, regardless of which kind of coverage they move into. Currently, as I mentioned, that Part B premium is $148.50. That's your baseline. How much on top of that you spend is going to depend on which way you go coverage-wise. If you go with a Medicare supplement, we are going to recommend a Plan G. We used to recommend Plan F, but Plan F was eliminated by legislation in 2020 because it was decided that no such plan shall exist that eliminates all cost sharing, which is what an F did. So now that F has gone away, we recommend the next level down, which is Plan G. And the only difference is with the Plan G, you are responsible for your outpatient deductible, which is one time annually this year, $203. What it will be next year, we won't know until the fourth quarter. Once you come out of pocket, that $203, and that's strictly outpatient, Medicare will pay 80%, the supplement the other 20%. The $115 premium quoted here is an average premium associated with a Plan G Medicare supplement. It could be a little less, it could be a little bit more. Add to that the prescription plan. The national average prescription premium currently is $33. Once again, depending on your scripts, you could be paying a little bit less than that or a little bit more. What drives the selection of a Part D plan is very simply your prescriptions at the time of enrollment. Same principle. You don't get better prescription coverage by throwing more money at it. You're just spending more money. During open enrollment, each fall, the suggestion is that everybody has to change their plans or something terrible is going to happen. And in reality, that's just not true. A small percentage of people need to switch up their coverage. However, the number one reason people need to change their coverage is almost always because of drug costs. If you're taking even 2 brand name prescriptions, it's something you'll need to shop with our assistance every year because it's that expensive. As I mentioned earlier, if you're older going into a Medicare Plan G, Medicare Supplement G, the premium's going to be higher. The older you are, the higher the premium. And on the far right, Medicare Advantage. The vast majority of our Medicare Advantage clients are not paying any monthly premium. Some are, but even if they are paying premium, the premiums associated with Medicare Advantage plans are pretty reasonable. Nonetheless, they have to pay at minimum $148.50. So once again, if someone is in a 0 premium Medicare Advantage plan, technically their monthly insurance premium is whatever they're paying for Part B. When we work with folks who might have gone to a seminar like this, we get referrals from current clients, from financial advisors like Tom and his crew. The first thing we do when we get that phone call is vet the situation to see what that individual needs to do next. Typically, because the Medicare market is so noisy and misleading, many people think they have to do a lot more than they actually do. So we go through that whole process to help people understand what their next steps are. If in fact moving into Medicare is indicated, we get them enrolled if they haven't already been enrolled, and then we schedule a time to go over coverage options. Currently, we're working in somewhat of a hybrid mode. We're back in the office, everyone is fully vaccinated. Some people, however, are still choosing to do conference calls, which is perfectly fine. I've done hundreds of them in the last 17 months, and they work just as well as a face-to-face. If we do schedule an appointment, whether it's virtual or in the office, we do a lot of background research ahead of time. Medicare requires that we get authorization before we can even do that research. So we'll address the authorization and then request information regarding doctors, et cetera, and that helps us do that research. When we do meet, whether it's by phone or in person, we talk about plan selection. People often say, what do you normally recommend? We don't, because you know your hot buttons better than we do. Once you land on what you think is best for you, we assist you with enrollment. It's all done electronically. When we submit your enrollment, it goes directly to the insurance company. Once you're enrolled, we're available throughout the policy year should you have questions. And then our heavy lift is during open enrollment. Unfortunately, the government gives us all of 8 weeks to help hundreds of people, and there are only so many hours in the day. If there are changes necessary, we assist in getting our clients in a different plan. So with that, Tom, do you want to open up more questions?
Well, thank you, Kerry. I knew that you would cover a lot of ground, and you certainly did. And so some of these questions we've received before the workshop even started, and you addressed many of them But just for clarification, I'll submit some of them to you.
Sure.
One question we got several different ways is about the prescription coverage, Part B.
Mhm.
And a number of people are concerned because they take very few prescriptions currently. The question is, do they even have to sign up for it now? But if they wait, are there penalties or additional costs because you didn't do it from the beginning?
Yes, there is a penalty. And there's no set penalty. It depends on how long you went without coverage. To give you an example, go ahead. So again, you don't have to take out Part D, but if you don't elect it when you're first eligible and you're not still covered by an employer plan where the drug coverage is available, you will be charged a late enrollment penalty. How much depends on how long you went without coverage, and that penalty stays with you for the rest of your days.
So is it a meaningful penalty? Is it an onerous amount?
It's, well, it depends. I guess that's perception. I can tell you, again, Medicare Part D has been around since 2006. So here's an example for you. In 2019, we had a run on people that were otherwise eligible in 2006, but never had elected drug coverage. Now they were. So this was the fall of 19. Whatever they were going to elect was going to go into effect January 1st of 2020. So we were looking at a 14-year penalty. It amounted to be somewhere between $55 and $60 a month. So that penalty will be applied to that person's monthly premium going forward.
Got it. Good example. We have, this question basically has to do with how Medicare premiums can change based on people's income. This person asked, I'm looking to sell a property this year and expect a big spike in my income. The gain on the property, and good for them in this example, is over $500,000 of profit. A friend told me that my cost for Medicare will really go up. Why is this, and is this true? When should I expect the cost increase to go into effect? And is it permanent? And is there anything I can do about it?
Great question. Part B, as I mentioned earlier, is means tested. So it's always going to be driven by your reported income. It does not necessarily stay fixed. It goes up and down with reported income. So to this example, I had a call not long ago from a client who's been in Medicare now for a few years, paying the standard Part B premium, and suddenly received notification that his Part B was going to increase fairly significantly. And he was questioning, well, why would that be? And my first question was, did you sell something and thus had capital gains? And in fact, that's exactly what happened. So for the next year, he's going to be paying more for Part B. As quick as the government is to raise Part B because of income or something like capital gains, shocking, they're not as quick to necessarily bring it back down. So it's something that we encourage our clients to bird dog, because you cannot make the assumption they're going to look at it on a timely basis. There's an actual form that we send to our clients every day. It's an IRS petition, where if down the road you think that you should have had an adjustment and it has not been made, you can petition Social Security to review your situation. Now, it's also not uncommon for someone to come into the office and say, well, yeah, I made that in 2019, but now I'm retired and I have little to no income. Many, many, many of our clients are successful right out of the gate, saying to Social Security, hey, I've had a life change. It could be divorce, it could be death, it could be work stoppage, it could be a reduction in hours. If you can make an argument to Social Security that you've had a life-changing event, oftentimes you can get Part B reduced, if not to the standard, perhaps the next level down. Currently in 2021, Part B maxes out at about $504 a month, and that assumes modified adjusted gross income for a married couple in excess of 750,000. So yes, it can change, and it doesn't typically stay fixed unless you're lucky and you live in a high income bracket for the rest of your days. I have clients that are now in their mid 70s who are still paying IRMA, income related monthly adjustment on Part B, because they were fortunate enough to make some good investments.
Yeah, and Kerry, we've had situations where people thought that was based on what their taxable income was after deductions, and only to find out it's a modified adjusted gross before deductions that they look at.
Yep.
Real common, we've found.
Something else, Tom, before I forget to mention it, something else that I've seen a run on recently, and I don't know if it had to do with the new tax code a few years ago, but while it might make sense prior to Medicare eligibility for married couples who are filing separately, it's disastrous when they move to Medicare, because the threshold for an individual filer is half of what it is if you file jointly. So many people have gone back and have actually considered doing amended returns because they didn't realize it was going to be a bad situation moving into Medicare.
It's a good point. We have a number of people, I think, fall under this question, that I have coverage from an employer and I plan to work until I'm age 67.
Mm-hmm.
I'm not taking Social Security yet. Do I still have to enroll in Medicare at age 65 for Part A? And what about the other parts? How do I let Medicare know that I'm staying on my employer plan for now?
You don't have to put Medicare on, well, Social Security technically on notice. The bigger question is, if you're going to work beyond 65, as I've mentioned, don't assume the employer plan that you have access to is your best bet. It may or may not be. You need to at least do the math. And people will say, really, I can still work for my employer and not use their coverage? Well, of course. No employer is going to say, oh, please stay on the plan. We want to continue to pay for you. So it's a matter of doing simple math. You do not have to apply for Part A. There are times when we counsel people not to. HSAs and Medicare do not mix well. The IRS makes it very clear that when you become Medicare eligible, you are not to make any HSA contributions, nor is the employer, unless you do not apply for Medicare or Social Security whatsoever. That's a loophole. However, what's inherent in an HSA is a high deductible. The beauty of moving into Medicare is while you may have co-pays with a Medicare Advantage plan, you're not facing high deductibles. If I had my druthers, everybody turning 65 on an HSA would just simply get out of it and move to Medicare, because the penalties that you can face aren't worth it. If you defer Medicare, as I said, the burden goes on you to show the government that you've had coverage, and you have to submit those documents. Most people come into Medicare and they're not drawing Social Security. Most people wait until they reach full retirement to draw Social Security. And now the new trend seems to be waiting until 70. A good example of the HSA situation is I will get a call from someone who'll say, I'm trying to decide whether or not to stay with my employer plan or move to Medicare. Well, again, it's simple math. My first question is, what are you paying for your employer plan? That person might say $150 a month. Well, I know, having come out of this from the employer perspective, that that's pretty low given today's standards. It also suggests to me that they're probably in a high deductible plan if they're only paying that much premium. So on the face, that person says, well, I'm paying $150, it would cost me $148.50 to move into Medicare. Why would I do that? Then I ask my next question, which is, what is your deductible? And typically what I hear is something in the neighborhood of $3,000. Well, that changes the conversation. Unfortunately, most people don't pay a lot of attention to their deductible, especially if they're healthy. But what you should do, in this case, that person should take that $3,000, divide it by 12, which is $250, and add it to the 150, now we're at 400, and that's a more reasonable representation of what you could face out of pocket if you were using your coverage. So for that person, I'm going to say, you know what, you're probably better served moving into Medicare to get out from underneath that deductible.
Very good. These things can get challenging.
Yes.
Here's a question from a client who's concerned about their parents who, according to this question, my parents are on a fixed income with very few assets. I'm concerned about the cost of healthcare, in particular, how they can even pay for Medicare. Where can they get help?
Well, depending on their eligibility, they may be eligible for extra help through Social Security for their prescription costs. If it's a question of decreasing or lower income, it would be a matter of pursuing Medicaid eligibility through Job and Family Services. Now, if it's a question, keep in mind, and we get these calls a lot, anybody over the age of 75, 80 will have come into this world where the only option available were Medicare supplements, and they do get expensive. I worked with the parents of a close friend of mine a couple of years ago. They're now 80. They both had Medicare supplements and Part D prescription plans. They opted to move into Medicare Advantage, and in doing so, it freed up $650 a month in premium, which is a lot of money when you're on a fixed income.
Wow.
So yeah, there are, but on the other hand, if it's just someone who says, hey, my 95-year-old mom wants to save some money and I'm thinking about moving her from a Medicare supplement to an Advantage plan, my first question is, are you sure that's the hill you want to die on? Because change at that age can be not worth all that goes into it. So we try to be very careful when we're giving guidance to be sure that everybody understands the potential pitfalls. We don't want to rob from Peter to pay Paul.
Sure. Here's a question that we hear a lot. There's dozens of these different versions of Medicare supplements. They all use the same letters. They appear to have the same standardized benefits. Why is there such a big difference in the cost?
It's essentially what the market will bear. You know, all of these companies have to go to the Ohio Department of Insurance and get approval for their rates. And if they get approval, they can charge whatever they want. What's unfortunate is that most consumers are not aware that a Plan G works the same way across the board. We made a decision many years ago to only work with the top guns in this arena because in this case, bigger is better. The more policyholders an insurance company has, the more competitive the premiums as well as increases. So that's why they can charge different premiums. There's a federal publication that speaks to Medigap policies. Publication hasn't changed. I don't think it's changed at all, at least a decade, right down to the page number. The publication is probably about 50 or 60 pages in length, lots of good information within it. To me, the most important statement in the entire book in bold type says there can be big differences in what insurance companies charge for exactly the same coverage, period. So you always want to get in as low as possible with a reputable company. Years ago, we entertained working with a company that came into Ohio, beating its chest about these low premiums, and they were. We hemmed and hawed and then finally decided to take the bait, only to have egg on our face in about 6 months because they started imposing 25 and 30% premium increases. Well, that's when we made the final decision to only work with the big guns because as we talked it through, it made complete sense. You know, if the big companies struggle to keep a lid on increases, what's a small no-name company going to do?
So what I'm hearing you say is these plans pretty much are standardized. And
100%.
it really is possible to pay way too much for the same thing.
Absolutely. And one important point to make, and this is also a nuance that most people are not aware of, When you first come into Medicare, or you're within 6 months of your Part B effective date because you're just now retiring, both Medicare supplements and Medicare Advantage plans are available to you with no medical questions. You are guaranteed either one. The law says you have 6 months from your Part B effective date to be guaranteed a Medicare supplement. If you apply for one beyond 6 months, you will be asked medical questions. So the message to people is, if you think a supplement's the way you want to go, the time to do it is when you're first eligible. Also, there's some misconception about why there is medical, because people will say, well, gosh, I thought the Affordable Care Act got rid of pre-existing conditions. It did for people under 65. Here's the nuance. The reason why a company offering a Medicare supplement can ask questions after the fact is because they're not technically insuring you. They are supplementing Medicare, who is your primary insurer. So in other words, when you enroll in a Medicare supplement, you need to be mindful that you're paying that insurance company a monthly premium to basically write checks on your behalf. They are not weighing in on your treatment and whether or not it was necessary or appropriate. They're simply waiting to be told, after Medicare pays the lion's share, what's left to pay. So now, after the fact, they can ask you questions because now they're just making a conscious decision on whether or not they want to pick you up as a risk. On the Advantage side, there are no medical questions. So potentially it's easier to move from a supplement to an Advantage plan than the other way around because of that medical underwriting. To say that if you start with Advantage that you can never go to a supplement is not true, but you just have to be mindful that you will be asked medical questions.
I just had a client pop on a question, and I think this may be affecting people that have birthdays in January and February. When should they actually contact you about enrolling in Medicare? Because you're going to be in the height of your open enrollment season when they should probably be applying. What would you advise them?
Well, we certainly are sensitive to that. And I'll be very candid and tell you that I always feel a little sorry for those folks that are either retiring or turning 65 in the first quarter, because you get caught in that crossfire. But we accommodate everybody. Just because it happens to be the busiest time of year doesn't affect how we still help people. Because you have to. I mean, you still need the guidance. It's just unfortunate that it is that crazy time of year. But I promise you, we can handle it.
I think we have time probably for this last question. So Kerry, thanks for all the great information. It's been very helpful. They go on to say they'd met with someone from local senior services about Medicare. They were very nice, but they told me they aren't allowed or to even make a recommendation of which company I should do. Mm-hmm. I'm really confused though, because I don't know which company to use. And this is kind of a loaded question for you, but where can I get a knowledgeable person who will help me determine what's the right policy for me and not just try to sell me the one policy their company issues? Right.
And that's where we know that we are valuable to people, because we are independent and we're not married to any of the companies nor options. Our role truly is to educate and facilitate. Over the years, I've told people, I almost see myself as somewhat of a glorified social worker. I have no interest. We have no interest in which way you go. We're about doing the right thing. And if people understood the regulations and all that we have to go through, there's a reason why we're the only game in town, truly. One of the challenges that we face in Ohio, and this is not peculiar to Ohio, as long as an agent broker has a life and health license, they are able to market Medicare supplements without additional certifications, and a lot of certifications. They cannot speak to Part D prescription nor Medicare Advantage. So we still get calls from people who say, I worked with an agent who said that Medicare Advantage is the worst thing ever. Well, I'm willing to tell you, I'll put $100 on the table and tell you it's because they can't speak to it. So, you know,
Sure.
our feeling is people need to be exposed to the entire playing field, not just one option.
And
And
Kerry,
there
what
are,
I would tell you that I think it's why we get such good feedback from our clients who you serve, because our processes are very similar. You know, we try to work as objectively, and we try to position ourselves without conflicts of interest as much as possible. And if there are conflicts, we certainly disclose them. And I know we're out of time. I just want to tell you thanks
oh,
for
you're
your
welcome.
time today. We've got a number of people that have raised their hand that they want to contact you. I just got another text or question came in. I've been watching a lot of webinars, but this one was excellent. Thank you, Kerry. You are clear to understand. Well done. I really appreciate it. I think that goes for us as well. So thank you for your time. We look forward to working with you as we go forward. And I'll just remind everybody on the webinar to please watch for our emails about upcoming webinars. Mark your calendar for August 18th. When you see the email invite go out, please make your reservations. And those of you who are on the call today, we do record these sessions. It will be available for your review later. We'll also have it available to anyone who wants to listen. So if you have a friend, a family member, a spouse who wasn't able to join you today, but you really wish they could have, please look on our website, email Cassandra at McCarthy & Cox or myself. We'll make sure you get it. So with that, we'll wrap this up. Thank you for a great day. Get out and enjoy the weather. Stay safe. And Kerry, once again, thank you for all you do.
Oh, thank you, Tom, for having me. I really appreciate it.